study is one that was done basically to look at how much money that patients and their families are peeking out of their pockets, like Dr. Cornell has already said, as a result of looking after a family member that is critically ill. And moving forward, I have no conflicts of interest, and the study was supported by a welcome award. We shall have a couple of abbreviations used in the presentation. I thought it's wise to have a look at them first. OOPE is out-of-pocket expenditure, and that's simply the cost incurred by individuals or households at the time of receiving any healthcare services in the ICU. We have catastrophic health expenditure. That is any expenditure for medical treatment that can pose a threat towards the household's financial ability to maintain its subsistence needs. And the global threshold for CHE is 10 to 25% of the total household annual income. ICU and MV are well known to most of us. So iCOPE was a multinational observational prospective study in African and Asian countries. That is ICUs across the network, and all patients admitted ICU during the study period were recruited. Recruitment basically took 14 to 28 days. And right from the start of this meeting, we have had talks, and a couple of them have shown that critical care capacity in the country is growing. Well, it's a good thing. I'm not sure if we shall be able to afford where we are heading to. Shall find out that. But as ICU access is increasing, the cost of services in the ICU is also significantly high. And these costs have an impact on the perception of the care, the access, and continuity of the care. We are having growing ICU services in a country where the population is not covered. Covered, I mean, in terms of insurance, government coverage, and mostly it is the individuals that are picking money from their pockets to cater for the needs. So this leads us to catastrophic health expenditure. We said any expenditure on medical treatment that threatens the ability of a household to sustain its basic needs. And I hope the online team is still on. So there are risk factors and coping mechanisms for CHE. And then the knowledge gap, well, little has been known as far as how much patients are paying out of their pockets for their ICU costs and where they are getting this money, how they are coping up with the costs. So this project aims to quantify the cost of care. So the study aims of this project, the first one is to quantify ICU care related out-of-pocket expenditure in the participating ICUs, that's ICUs across Africa and Asia, to identify risk factors for catastrophic health expenditure and coping strategies for out-of-pocket expenditure and catastrophic health expenditure. So the hypothesis, we had a couple of hypotheses formulated, and the first one, mechanical ventilation, being an expounding factor. It has a doubling effect on catastrophic health expenditure incidence. The risk for catastrophic health expenditure and magnitude of out-of-pocket expenditure, and then part of the hypothesis. So the recruitment period for each site was consecutive 14 to 30 days from the start, and we had daily follow-ups in the ICU. After a patient was discharged from the ICU, we had a follow-up at 30 days and also at 6 months. Our data entrants could make calls to the respective patient families. The inclusion criteria: all patients that were admitted in the participating ICU that were expected to have a duration of stay greater than 24 hours. This expectation was not made by the research team. It was a decision by the clinical team, and lack of consent was an exclusion criteria. We had a couple of endpoints. One of our primary endpoints was the out-of-pocket costs per complete patient episode, the relative risk of catastrophic health expenditure in ventilated versus the non-ventilated groups. First secondary endpoint, we have risk factors for catastrophic health expenditure and the frequency of different coping strategies. Tertiary, we have proportion of direct versus direct non-medical costs, and then patient, family, socioeconomic status. So during the data collection and handling, all the data entrants here have interacted with these three interfaces. First, we have the CRF that was used to collect the data. So we had information being used from both the registry, that's Protect, and then our electronic platform, that's the RedCap. So these were being used interchangeably. So in Uganda, we had a total of 10 participating ICUs. The participation was phased. We had 3 sites participating in the first phase, that's Mbale, Case, and Barara. And then later on, we had 7 sites, as you can see there. We recruited a total of 38 patients, and 57 of these were from public ICUs. 81 of these were from private or PNFT hospitals. This is a summary from preliminary analysis results for the Uganda data. A total of 138 patients were recruited, and the average yearly income for patients in public ICUs was 1,080 USDs. Averaging patient in a public ICU was having a monthly income of 90 USDs. That is roughly $3 a day. The total public ICU costs on admission day were averagely $45. And when we go back to our threshold for catastrophic health expenditure, that's 10% of the annual income. Just on the admission day, the family is already spending 4%. From the previous presentation, we saw that averaging patients in our ICUs take about 10 days, they are still alive. Just on admission day, you are spending 4% of your yearly income, and 62% of this money was spent on medication. We can see where the biggest share is going. Well, the patients on mechanical ventilation and those not on mechanical ventilation, on day 1, there were no big differences like we had expected in the hypothesis. We can go ahead and look at a summary from private ICUs and PNFTs. The average yearly income for patients in private ICUs or PNFTs is 6,744 USDs, and the total ICU costs on admission, they are averagely $502. That's 7.4%. but we are very much aware that most times our patients in the private ICUs are insured patients. Most likely all this cost is not falling into the pockets of the patients. 34% of this is spent on ICU bed charges. So the thing taking most of the cost in private ICU is not medication, as we had seen in public ICUs. And also on admission day, the costs were comparable between the ventilated and the non-ventilated group. We have something to compare with. That's a results summary from the ICUs on the network. A total of 5 to 6 patients. That's 267 from public and 259 from private. Average yearly income for patients in public ICUs, $2,004. And here the total ICU admission cost on day one is $56. That's 2.79%. And it's also true that they spend much of this on medication, just like we do in Uganda. The cost for the ventilated and non-ventilated group is comparable. For the private facilities, average annual income is $6,852, and total ICU admission costs are $460. That is 6.71% of the average yearly income. 25.2 of this money was spent on bed charges. Patients on mechanical ventilation spend approximately 808 USDs on day one, and those not on ventilation spend $380. A striking difference, almost twice. The mechanically ventilated group are paying as compared to those that are not mechanically ventilated. This data is still under work, not yet published. I'd like to extend thanks to the Association of Anesthesiologists of Uganda, the whole team, technical team of the registry, and all the data entrants for making the study wonderful progress. Thank you everyone for listening.